Hi, everyone. My name is Daisy. I am pursuing my MBA and my MPH at Yale right now. And this past semester, I've been working with Laurel alongside Fuati and Stephanie and Ella, who will introduce herself in a second, to sort of assess the state of maternal and child health in Southeastern Connecticut, specifically for mother and infants of color. And so here we'll be presenting sort of our research from this semester and recommendations. Ella, you want to quickly introduce yourself?
My name's Ella. I am a senior in the Bachelor's of Public Health program at Northern Arizona University. Also working with Laurel and Daisy and everybody at L&M. And while Daisy has been working on the data sides of it, I've been working on the evidence-based practice research side of it, and looking, specifically in the community. And we're very excited to show you guys this today.
Thanks, Ella. And just to confirm, does this look like it's like full screen for everyone, like presentation mode?
Yeah.
I'm just making sure. Okay, so this is a quick run through of what we'll go over today. So we'll start with some of the work I did on some secondary data analyses and some existing reports, a lot of it from the Connecticut Department of Public Health, as well as from L&M. We'll then switch over to Ella, who will provide some high-level insights from a really insightful conversation we had with a number of providers and community health workers in the New London area with some key takeaways. We'll then do sort of a similar exercise, but around conversations that Stephanie was really gracious to have with some Black mothers in the greater New London area, and some of the highlights from those conversations and key takeaways. And then I'll turn it back to Ella for a run through of evidence-based practices and some interventions, so that we're not just looking at the inequities that exist, but trying to be actionable about them and make sure that we're moving forward. So with all of that said, and we'll leave time at the end for questions. So with all that said, we'll start, excuse me, with an overview of the existing data. And the way we'll go through a number of different sort of lenses. So we'll start sort of zoomed out at the Connecticut level, and then try and zoom in to discharges from L&M specifically. And we'll look at a couple of different types of outcomes. So we're going to start, and this is not my work, I pulled this from the maternal mortality review, which is a task force put together by the Department of Public Health in Connecticut. And this is their most recent report on maternal mortality in Connecticut. So they look through death certificates and assess the state of maternal mortality. And so from the report, we can learn that between 2015 and 2017, which is the most recent report, there were 11 pregnancy-related deaths among all women, so altogether, which averaged about 3 to 5 a year. The committee assessed that over 80% of those pregnancy-related deaths were preventable, identified as preventable. And as you can see in this little graph down in the bottom left, as well as in the text on the right, persons of color were overrepresented in this group. So while they made up about 64% of those deaths, they made up only 45% of the live births. That sort of overrepresentation among adverse outcomes is going to be an unfortunate trend that we're going to continue to see in this data. So then switching the lens a little bit, we're now going to talk a little bit about infant mortality. So switching from mother's outcomes to outcomes for the infants, just to orient everyone on this graph. So we're looking at these outcomes in terms of rates per 1,000 live births, and it's by geography as well as by race. So you can see how what the rates were for women in these different geographies dependent on race. So for example, in Connecticut, there were 5 deaths per 1,000 live births for Hispanic infants. And so sort of some high level takeaways here, we can see that among all geographic subsets, Black and Hispanic infants died at higher rates than their white counterparts. That the disparities that exist for Black infants are reduced from 9.5 per 1,000 births to 6.5 and 5.6 respectively. So they're reduced in New London and Greater New London, though clearly not eliminated. Disparities still exist. The rates are still higher for both Black and Hispanic infants compared to their white counterparts. and that in Greater New London and New London County, Hispanic infants fared the worst in terms of infant mortality. And I'll pull back a little bit quickly and just say that one, a lot of the statistics we'll show here are really just descriptive. So just due to sort of time and data constraints, we weren't able to do sort of inference analyses or causal analyses. I can't explain with the data what's driving these disparities, but just to say that clearly they exist. And taking a moment now also, and we'll do this later when we talk about the conversations, but that we're presenting a lot of numbers and talking about them as numbers, and maybe to Isabel's point before about speaking about data in an empathetic way, recognizing that these are real people and just bringing that human lens. That said, we'll move on to the next, which is sort of moving into sort of different adverse birth outcomes and characteristics. So here we're looking at that same geographic and racial lens. The color coding is the same. So for also in rates per 1,000 live births, we're looking at low birth weight outcomes, preterm birth outcomes. And this is a characteristic of the mothers, which is whether or not they had late or no prenatal care. So that's no prenatal care or just prenatal care in the 3rd trimester is the definition there. And again, overriding theme here is that in terms of rates per 1,000 births, Black infants and here Black mothers had the highest rates, both of low birth weight outcomes, preterm birth outcomes, and lack of access to prenatal care. And all of these data are taken from the Department of Public Health's Vital Statistics 2016 to 2018. So then the next and then the last set of analyses we did from this set of data is around the use of certified nurse midwives. So you can see that in New London County, certified nurse midwives are present for a higher rate of births for white infants, but in general are leveraged less than in Connecticut at large. So there's just a geographic disparity in the use of certified nurse midwives in New London. We spoke to Laura a little bit about this, and it seems like there maybe were some former regulations that limited the use of certified nurse midwives, but this seems like a pretty clear area for intervention. And just in general, research has shown that the integration of nurse midwives leads to significantly improved outcomes, certainly for Black mothers as well. And so upping these rates, one would think would lead to improved outcomes, and Ella will speak to that a little bit later as well. And then lastly, the last sort of set of analyses we did were from using data from L&M specifically. So we took discharge data from April 2017 through March of just this past March. And we limited that to L&M's primary service area, so the 10-town service area. And just to orient everyone on the graph, since it looks a little bit different this time, we're no longer looking at things by geography anymore. This is just by race ethnicity of the infant. And the sort of the 2 bars show us how that race was represented among all births versus how they're represented among this adverse outcome. So in this case, we can see that white infants were sort of quote unquote underrepresented among low birth weight outcomes because they're 63% of the total population, but only 55% of the low birth weight outcomes. On the flip side, and this gets back to that unfortunate overrepresentation, right, that Black, Hispanic, Asian, and American Native or Alaskan Native infants were all overrepresented among low birth weight outcomes. This is premature outcomes, and again, we see those same trends. Black infants, Hispanic infants, and in this case, American Indian or Alaskan Native infants were all overrepresented compared to their representation in the population for premature outcomes. And then the last, we look at the distribution of NAS diagnoses by race. NAS is neonatal abstinence syndrome. It's typically indicates that the child was exposed to typically exposed to opioids during the pregnancy. And so we can see here that there's disparities for white and for Black infants. And so really calls for intervention for all mothers in terms of substance use during pregnancy. And so wrapping that all up into, that was a lot of numbers, were sort of the key takeaways. So while New London County fares slightly better in terms of certain Black maternal and infant outcomes than Connecticut at large, within New London, large disparities still exist between outcomes for Black and Hispanic mothers and infants versus their white counterparts. And again, bringing it back to the human element, these data substantiate what we know to be true, which is that racism persists in our healthcare system and is a public health crisis, as this group has recognized. We noted that access to prenatal care and certified nurse midwives are clear areas for intervention. And then areas for further research, additional analyses on outcomes for mothers could be really helpful. So adverse outcomes for the mothers themselves, things like preeclampsia, gestational diabetes, outcomes for mothers that maybe indicate some adverse event. Those can be conducted using CHIME data, which is the Connecticut hospital data. So that's an area that we recommend looking further into. Regular analyses of these Connecticut vital statistics data will show how these trends fare over time, which would be helpful to keep a pulse on. And then and I mentioned before, these data show existing disparities, but really more research is needed into causation and association. And with all of that, I will pass it over to Ella.
Great, thank you, Daisy. So we had meetings with a couple of providers who kind of gave us insight on what they thought was going on in the community and what they thought could work better in the community. You can go ahead and click over. Oh, there we go. So these were the three key points that we talked about kind of as barriers to effective care. The first being community representation, in that the providers in New London as a whole kind of don't represent the community and the mothers they're serving, and that mothers from the group also said that they felt a little less comfortable or felt that they didn't receive the same care because their physician or their nursing staff weren't representative of them, and that providers did note that the diversity was lacking, and the providers of minority backgrounds would benefit the community. And then the second one was the comfort of services, and providers from the midwife group actually said, from Coastal OBGYN, said that they offer free necessities like car seats and strollers, diapers, formula for mothers in an environment that they're already comfortable in. So they were more likely to use those services than they would be to get it from somewhere else. And then some of the providers in the labor and delivery unit at L&M also talked about offering 211 or state services to parents for things like childcare during delivery or transportation. And it was often denied because the parents had a stigma against using these services, thinking it was a bad thing, thinking that they would be seen as negligent parents or that their children would be taken from them because they didn't have the time to take care of them during the birth process. And then the last one, like Daisy touched on, was the lack of access to doulas or midwives, that the L&D unit doesn't see as many mothers with midwife services. And we actually had a big conversation with Coastal OBGYN about that they don't see these same racial disparities in their practice, that the anybody that goes kind of have the same positive outcomes because of the care they're receiving. So whether that's indicative of their care or not, we think that doulas and midwife care would really benefit these birth outcomes. And I'll pass it back to Daisy so she can talk about the lived experiences conversation.
Thanks, Ella. So now I'll present this, but this is really Stephanie's work. Stephanie was gracious and gave her time and spoke with a number of Black mothers in the greater New London, Southeastern Connecticut area. The highlights and quotes that we'll present here are from a specific conversation with 4 mothers in the area, but Stephanie has gone on to have more conversations that we'll continue to incorporate into the work and any other deliverables we produce through this. I regret that we didn't have time to, we didn't incorporate them into this, but hopefully this will still give you a real sense of the lived experience of mothers going through birth. So the first sort of vital insight that we took away was that information matters, but so does the way that it is relayed and from whom. On all these slides, there'll be some quotes on the right. I won't read those, but I invite you to. But I'll talk to some high-level insights. So often women felt that they didn't receive adequate information about their own health, including the warning signs for complications. Sort of from that, women also felt that they weren't adequately prepared in the event that things didn't go, quote unquote, as planned, that maybe certain vital information wasn't provided to them in terms of how the birth might go and might not go perfectly. And that also often when information or resources or advice were provided, it was done in a way that could be condescending or insensitive. And so it's not just about giving the information, it's giving it in a culturally competent, relatable way that empowers the mother to use that information. So that was certainly one of the key insights. And I'll just give everyone a minute or 30 seconds to read that quote before I flip. The next key insight is that Black women are too often ignored or doubted when voicing their pain or their preferences. I think this is something that we hear about, but it was made really real by this conversation and these women's experiences. I mean, not one of them didn't have a story about this. One woman was shut down when she expressed a preference for natural alternatives, sort of a little bit demeaned by the provider for that preference. Another felt forced into an epidural, which then cascaded a series of events resulting in an unforeseen C-section, sort of despite her requests. And women were consistently doubted when voicing their pain and felt that they had to prove themselves when they were feeling really real pain. And so again, I'll give a few seconds for folks to read the quotes. And then the last insight is that representation in healthcare matters. And I'll let this quote speak for itself. And we'll just say that research shows that Black patients fare better when they are seen by a Black doctor. And so it's important that we raise up more Black physicians and Black nurses from the community because that can be the difference between life or death for some folks. So thank you again to Stephanie for doing this and for providing us these insights. Hopefully this gives a real human element because this is a human issue. And with that, I will pass it back to Ella so that we can talk about how we can work to eliminate these disparities.
Thank you, Daisy. So I'm going to talk about some evidence-based practices and recommendations that through my research I've noted that coincides with Daisy's awesome data that she's been researching. So the 4 things I'll kind of touch on, you can flip to the next slide. Oh, there we go. All right, are improving bias training in facilities, providers that represent the community, supporting doula legislation, and the centering pregnancy model that kind of as a whole was a big part of my research. So the first one is improving bias training in hospitals. And this is reducing the unconscious bias in healthcare providers, and it can greatly improve the quality of maternal child health visits for Black mothers or mothers of minorities. And the March of Dimes is doing this very effectively through their bias training, which covers these 4 topics, which is the overview of implicit bias training and your personal assessment, which is to see kind of what your implicit or unconscious bias is, that obviously you may not know about. The historical overview of structural racism in the United States, kind of where these biases come from and why they're still around. Strategies to mitigate racial bias in maternity care, and building a culture of equity within an organization. So again, encouraging providers to, encouraging minorities to become providers, and also encouraging people to speak up about racial bias in their organizations. And the second one is providers that represent the community. And the mothers from our lived experiences group said they were more comfortable when their healthcare staff represented them. And it kind of touches on this quote that's on the left, that I'll encourage you to read. They also stated that they felt they had to prove themselves worthy of equal care during complications in their pregnancy. And this was most often when they didn't have staff that represented them or didn't have staff that listened to them. We had a couple of mothers say that they, were uncomfortable with, seemingly small things like their IV or their catheter, and they were kind of ignored about it until they, really had to speak up for themselves and prove themselves. And another organization that's working on this is the CDC's Hear Her campaign, which empowers women to speak up about their concerns and raise awareness for the common complications. And it actually presents first-person videos of women talking about their experiences and their struggles with prenatal health issues to raise awareness about, what is happening. And I'll give you, 30 seconds to read this quote and kind of think about it. All right. And the next one is supporting doula legislation in Connecticut. And as Daisy said, studies have shown that midwife and doula care are incredibly effective in reducing negative birth outcomes. These 2 little snippets kind of, I think, encapsulate it really well, because they spend so much time with the mother and the family. They kind of see the patient as a whole person, and they're really in your corner. They really listen to what you want. And some legislation that's happening right now is the Act Concerning Doula Certification and Medicaid Reimbursement, which is CTSB 562. And it's providing state certification of doulas and also Medicaid reimbursement for those that provide services to families covered by Medicaid. So this would increase the availability of doulas for those that wouldn't be able to private pay for them. And then the last thing I'll touch on is the centering pregnancy model and kind of prenatal group sessions. So Centering Pregnancy is run by Centering Healthcare Institute, and their overarching model involves 8 to 10 women and their support people to attend groups for prenatal care appointments and learning sessions. And they receive wellness checkups at every visit, and then all the mothers and the staff and support persons circle up to learn about and address health concerns. And then they also discuss what each group individually feels is important during their pregnancy. And through the conversations that we had with providers and some of our partner organizations, we did discuss that maybe it would be a little bit in depth, a little too in depth with, funding and availability for staffing and space, especially with everything going on right now with COVID-19. It may not work as a whole, but as some parts of it, I think that it would be really effective in our community to kind of touch on these 3 points, to build a network of support for mothers and their families, to encourage and help mothers focus on their own health by encouraging them to keep a wellness log, and centering pregnancy and the group sessions have shown to reduce occurrences of low birth weights. The barriers that kind of came up as I was doing my research and talking with people were the lack of reliable transportation and the lack of childcare. So, lots of mothers don't go to their appointments because they can't get somebody to watch their kids because they often can't bring them to the appointments. And then the low enrollment is trying to get women to come to the groups for whatever reason they can't. And that is it for me. I will go ahead and pass it back over to Daisy to finish up the presentation.
Great, thanks, Ella. So with all of that said, we just want to give everyone a couple of tidbits of news and research to keep your eye on regarding maternal health and maternal mortality and morbidity and infant outcomes. So the first at a federal level is the Black Maternal Health Momnibus Act of 2022, which was introduced March of last year and includes some measures on the federal level to improve maternal health outcomes. Ella mentioned it, but Connecticut SB 562 is the act concerning doula certification and Medicaid reimbursement. So that is another bill to keep your eyes on. In terms of studies, the Yale School of Medicine is conducting a Black maternal health study. It's happening now, so they're actively conducting interviews now. But I think they're slated to finish up within the next year or so. Publishing can take a while, but that is more qualitative research, interview based, and is specifically with pregnant women of color who have certain conditions, gestational diabetes, I think, preeclampsia, hypertension. So that's another, that should have some interesting and helpful insights. And then something to watch, Stephanie sent us this and I recommend everyone check it out. Vice President Harris had a roundtable on Black maternal health that was a really interesting conversation. So those are things to look out for and keep tracking. And with that, we'll open it up for questions.
So I think before we head into questions, we want to pass it to Sion or Devotion. And then we'll do some quick question and answer after the conclusion of her presentation. So Sayana, I just want to make sure that you're able to share your screen. Thank you so much, Daisy and Ella.
Hey everybody, thank you for having me again. I think I probably met some of you the last time I was here. Hold on, I'm trying to move something. But so you may be familiar with what it is that I'm going to talk about, but I've added some information, so here we go. Today we're going to talk about the benefits of doulas and the barriers that prevent family support. And kind of just what doulas are, for those of you who may not even know what we do. So Earth's Natural Touch Birth Care and Beyond doulas are doulas and perinatal health advocates who work to reduce the risk of undesirable pregnancy and birth outcomes. We promote perinatal wellness for parents and children and promote breastfeeding advocacy to all families, while also working to eliminate racial and ethnic disparities in infant and maternal health. So we're doing a lot of stuff here. There is a long history of women who specialize in supporting others during childbirth across many cultures, but now we're trained professionals. So we work in different areas of birth, from postpartum to birth to fertility to bereavement, and we provide emotional, physical, informational, and even logistical support to families. There are also doulas who focus on for adoption. I didn't mention that. And sometimes they're called other names like birth sister, birth keeper, birth coach, birth companion. So doulas can be the extra eyes and ears and hands, and we can be responsive to things that bring awareness to things that are outside of the range of normal. So in the postpartum period, we see that sometimes things can go astray, and we want to make sure that families are adjusting well, that they're taking care of themselves, that they're eating well. If they choose to nurse their babies, that they're able to do those things. You can see on the chart on the left that a lot of maternal death happens in the postpartum period. And so that is the time when people are going home and there's no one to care for them. Many times they don't have a visit with their provider for 6 weeks after they leave the hospital, if they give birth in a hospital. And then there's no follow-up, there's no check-in. And we find that that is an area where we have to improve. So how do doulas get trained? There are many different training organizations. Most of the training organizations have trainings that last about 3 to 4 days on average, and then you have some time to complete some requirements. The Earth's Natural Touch interdisciplinary doula training is 14 months, because we know that just after 3 to 4 days of training, it can be challenging to navigate all of the complexities that often come with supporting families in undervalued and underrepresented communities who are living with the weight of historical and generational traumas while navigating institutional racism and all of the social determinants of health, which can all influence our reproductive choices, options, and outcomes. And so in our training, we are focused on everything from conception to birth and postpartum, and things in between, like nutrition, grief and loss, toxic relationships, birth justice, trauma, breastfeeding, and so much more. So community doula models often connect families with resources that could help them with their needs. So if they need help with navigating housing or food security or clothing assistance, transportation, all of these things can help to reduce the social stresses that the birthing person may be experiencing due to their race, sex, or socioeconomic status. These issues, of course, disproportionately impact low-income African Americans. So this is Dr. David Williams. He's a professor at Harvard, and he says, basically, what we have found is that discrimination is a type of stressful life experience that has negative effects on health similar to other kinds of stressful experiences. We now know that discrimination is linked to higher blood pressure, to high levels of inflammation, to low infant birth weight. Discrimination predicts higher levels of mortality, and people who experience it are literally more likely to die. Doulas help to reduce maternal stress. So having a doula who provides psychosocial support can help reduce that maternal stress, which in turn has a positive influence on pregnancy and birth outcomes. Therefore, the inequities in pregnancy outcomes for Black and low-income women can be addressed by increasing access to doula support. Here I've added this slide because I think it's really important to understand some of the stresses that or stressors that Black women experience on a regular basis. When we're driving, we're concerned about being pulled over because we have examples like Sandra Bland. Just yesterday, we had George Floyd, the situation, and then not even an hour later, a 15-year-old girl was shot and killed by a police officer at her own home, and she called them for help. So who do we call when we need help? If you have a child who is going out of the house and he's just going on a stroll and he's wearing a hoodie, you have this fear because it's like, wait a minute, my innocent child is just going outside to hang out with friends, but he has a hoodie on. Is he going to make it back home? So we have a lot of concerns that a lot of other groups of people don't necessarily have, right? And so this adds on to that weathering effect and that allostatic load and that stress that impacts our health and birth outcomes. Doulas can help African Americans who face discrimination and often feel disempowered within the complex healthcare systems to navigate the system, and can even help mediate the effects of institutional biases within those healthcare systems. And many community doulas chose to become doulas specifically to take on the role of providing culturally competent support to birthing people. And I'm sure you all know, the US maternal mortality rate is just out of control. We spend so much money on healthcare, but we are performing worse than at least 50 other countries. And so as you can see, if you look at the Black column, we're shooting all the way up when it comes to pregnancy-related deaths. According to the CDC, how many pregnancy-related deaths do you believe occur in the United States every year? And I'm just going to give you the answer. About 700 pregnancy-related deaths annually in the United States. And we heard earlier from the presentation that some of those are actually happening here in Connecticut. 60% of those are preventable. I think the number here in Connecticut was 80% was preventable that they found. Across the United States, of those 700, that means that 420 mothers who died unnecessarily. We're not incompetent. We know when something is wrong. And the presentation earlier touched on this as well. The women who they spoke to were expressing that something was happening and they weren't getting the attention and care that they needed. This is happening across socioeconomic classes, educational status, and relationship status, as evidenced by the pregnancy-related death of pediatric chief resident, Dr. Shanice Wallace. She's down in the left-hand corner. Shalon Irving, next to her, was an epidemiologist at the CDC. Shamani Gibson, Shaija Washington, Amber Isaac, LaShonda Hazard, Kira Johnson, and the list goes on and on. And the common trend, of course, is that they were all Black and they were all ignored, just like the women that we heard about earlier. The CDC says that 60% of the pregnancy-related deaths are preventable, but they all died. Even Kira Johnson, who had a botched cesarean, may have been saved if her providers had listened to her husband when he told them that she was not doing well and alerted them that blood was in her catheter. Instead, they allowed her to bleed to death for over 10 hours. And Serena Williams, up in the upper left-hand corner, she had blood clots in her lungs. She told her providers exactly what she needed, and yet they ignored her. She could have died like all of the other women on this screen. And then there are their partners who are left with either taking care of their babies without their mothers or losing them both. Earlier this month, there was a woman named Alyssa T. in New York, 20 years old, just gave birth through cesarean section. She died the very next day. Doulas impact birth outcomes. So we know that having a doula can impact the length of labor. We can have an effect on the use of oxytocin and augmentation drugs, less vacuum and forceps use, higher APGAR scores, increased or near universal breastfeeding initiation, earlier onset of lactogenesis, increased breastfeeding length. And we know that breastfeeding is one of those things that can be implemented that can help with some of the issues that we see with our infants. Lower rates of cesarean section, lower incidence of birth weight, of low birth weight and preterm birth, less pain and anxiety, less use of pain medications such as epidural, and increased birth experience satisfaction. And these can all result in a huge reduction in medical costs. As the United States becomes more culturally diverse, healthcare professionals are well positioned to educate themselves, their colleagues, and their students about the tenets of culturally sensitive healthcare. Eliminating racial disparities in birth outcomes necessitates a thoughtful commitment from healthcare professionals, policymakers, and social and economic institutions to eradicate racism and the ensuing social inequities. What are the barriers and why break them? So, lack of information about doula services, lack of available doula services, cost of services, acceptance of services. African Americans often report receiving worse interpersonal health care than their white counterparts. There's also a huge trust issue based on historical trauma and mistreatment within the medical system. Doulas, specifically community doulas, who are among those populations and who have racial, cultural, and experiential similarities to the birthing person, can help to build trust with the parent and are in a position to be able to see and prevent overt effects of institutional racism, classism, institutional bias within healthcare systems, and then to mitigate many of those negative effects of social determinants of health that would normally impact the health of the birthing person and their children. Providing culturally relevant care and having racial concordance between vulnerable families and doulas can enhance the benefit that are already associated with doula support. And we heard earlier, there was one of the quotes that talked about, one of the parents wanted to listen to particular music and was comfortable because the rest of the people who were supporting her were on the same page. So how are doulas getting paid here in Connecticut right now? Either families are having to pay out of pocket, and of course, that is only coming from those who can actually afford the services. I run a doula program through New Haven Healthy Start, and our doulas provide their high-risk participants with doula support from the last trimester to 2 weeks postpartum. Again, we want to do more, but we have to have more funding. We get grants from organizations like the March of Dimes and through the ME funding, through Optimus Health down in the Bridgeport area. And then, of course, federal grants through state organizations. We have been working, of course, and are represented on the Doulas for Connecticut Coalition. We're a collaborative of doulas, community members, and other state and national organizations who are interested in helping families across the state gain access to doula support, and who also want to see doulas make a livable wage for what they do. The coalition was started in 2019 and has been working with our champion, Senator Moore, since then. We've also been working with the Public Health Committee leadership, Senator Abrams, Representative Steinberg, to introduce language to define a doula profession in this legislative session. And a bill was introduced this year, SB 1, this year, 2021, and we had a public hearing in March. But you can follow what's going on if you follow Doulas for CT on Facebook. And this is just how to keep in touch with us. Our website is earthsnaturaltouch.com, and we have a Facebook page, Earth Doulas, and our Instagram page, Earth's Natural Touch. We also have hashtags that you can follow if you're into that. Thank you.
Thank you so much, Cyanor, and thank you, Daisy and Ella. What an amazing amount of information. Just wanted to call attention to how, we have our public health data, but also talking with people affected by a health issue is critical to how we understand that health issue and identify solutions. So really glad to hear that in these presentations. Just wanted to open it up and see if there were any questions. I'd like to identify and answer questions, and then we'll be going and having a little bit of time in small groups with a couple of prompts to just kind of process all the information that you've gotten. So go ahead and ask questions. I'm going to share my screen, and also please take a moment to move your shoulders and make sure you're not getting stiff as you're sitting in your Zoom box. Questions, please.
I have a question for Cyanor, and thank you for the great presentation. The whole session is great. Daisy and Ella also did a phenomenal job showing the data and showing what's happening with this problem. I just want to know, do you have a count or a data showing how many doulas in Connecticut and also their demographic distribution?
So we've been working on that. I moved here from New York many years ago, but before I got here, I started looking for doulas that look like me. I've been a doula since 2001. When I got here, I couldn't find but a handful, literally, and they weren't doing the work. They were building their own families, taking care of their parents, and literally, I want to say like 3 or 4. One was a transplant from another state who was leaving. And so in 2016, I said, you know what, if I'm going to do this work, I have to have competent backup. And clearly we need doulas who look like me out here. So I started the training in 2016. Because my training is so long, we're not spitting doulas out every 3 to 4 days training. I could train hundreds of doulas, but I choose to make mine a little bit longer in order to make sure that they have the skills that they really need to deal with the population and the issues that we have here. And so, of course, we don't graduate as many. It takes us more time. But now there is more emphasis on what a doula is and what doulas do. And we see it in the media. We're hearing about it. And so you have some doulas that are kind of popping up, training with different organizations outside of ours. And we're trying to see if we can get a grip on that. And I can't remember what the numbers were, but I can tell you that we don't have enough doulas. I did sit down with the March of Dimes and we did some calculations to figure out if only half of the birthing people in the state wanted a doula, we do not have enough doulas. Because even with us, we have less than 100. And if I sat and just counted the doulas that I know of that look like me, not necessarily the white doulas, there are probably 10 more than ours. So we definitely need more doulas, and we want to make sure that they have the skills that they need to manage the issues that they're going to come across. Because I tell my students, being a doula is not just rubbing backs and holding hands all the time. It's not going to be all, roses and daisies. There's some real work that has to be done, because what are you going to do when you have a client who has no access to food, or who needs transportation to her appointments, or who needs some rent assistance? There are things that we really have to get into in order to be able to effectively help.
Thank you. This is very informative. And just a follow-up question to this.
Yes.
Are there certification process for
Yes.
doulas? It's
Yes.
run by DPH?
No. So DPH, I guess we are trying to see how things might go with DPH. Doulas are certified through their own individual training organizations across the country. And this is how it has been since doulas have become a profession. You choose the organization that you want to certify with, because that organization has something that you are attracted to. So you might want to become a doula with this organization because they focus specifically on women who are dealing with sexual assault or history of childhood sexual trauma, and that is the population that you want to support, so you train with them. You may want to focus on the LGBTQ community, so you'll find a doula training that focuses specifically on that community. Or you may want to, assist families in Black and Brown communities, so you find doula training organizations who are focused on that. And so we want to make sure that doulas continue to be able to choose the training organization that they want to train with, whether it's here in Connecticut or anywhere, that is going to give them the skill set to support the families that they want to support. So we don't necessarily want a certification through DPH, but we don't mind being recognized by the state as being certified with our own training organizations that we've chosen.
Thank you very much. Yes, I think it would be great if DPH recognizes this profession, and that will give you an edge, and also it will help you to, it will provide more advocacy for your role, which is really needed. Thank you so much.
Yeah.
Thanks so much for the question. I just wanted to kind of check in with the group. We have just about like 15 minutes in our meeting, so not a lot of time for small group work. I think it's a real opportunity for us to talk, since there's about 20 of us on the call and we have our presenters with us. So I just want to put up the small group discussion prompts and invite people to just share some reflections based on what they've heard. I think in particular, one of the things that is helpful for us to do as a HIC is identify the lessons that we hear from these presentations and our ability to make changes in our work and our workplaces to make things more equitable. So you know, I think there are some important themes that were covered in the two presentations that we heard around talking to people who are directly impacted by health issues and challenges and disparities and inequities, and also the way that we tell a data story. And I just want to kind of open it up and see if folks have some reflections.
Isabel, there is a question in the chat. I don't know if you saw that.
Sure. So what kind, if any, outreach what kind of, if any, outreach is there to find women who want to become doulas? Sayana, is that something you can speak to?
I'm sorry, I didn't understand the question. Hold on, let me see if I can see it. What kind of outreach is there to find women who want to become doulas? So I do my own advertising online. I do promote it, and I have noticed that just through social media, there are more people who want to become doulas. Unfortunately, we don't have as many people who actually want the doulas. Because they still don't understand what doulas are and what doulas do and how doulas can be a benefit to them. So that's really where we need to start pushing more information. Because being a doula now is kind of like it's like a trend, or it's kind of trendy right now. Oh, I want to be a doula, because I don't think people really understand what it means to really be a doula. Because the impression that we are given and the example that we have had has been from a white lens. And so most doulas in the country are white middle class married women. And so they don't necessarily have the issues and concerns that other populations have. So it kind of depends on the demographic that you want to serve and support that will determine what your experience as a doula is going to look like. Not to say that those populations don't have their own issues, because I mean, maternal mortality is just a mess in this country overall. But there are specific things that a white middle class married woman doesn't necessarily have to worry about that other populations do. And so when I explain to people what it looks like, and we go through a rigorous process. We put a call out to see who's interested. They have to write an essay. We do interviews. We call references, because I want to make sure that the people who I'm training are really wanting to do this work. I'm not interested in just certifying somebody just to say that they're a doula and they could potentially go out and do more harm than good. So I really want to invest in the community that decides that they really want to do this, to make sure that they have the skills that they need. Because I see doulas who are out there, they're going to organizations, primarily white-based doula training organizations, but they want to focus on Black communities, and those organizations are just not effectively training them for what it is that they're trying to do. And so they're leaving there unprepared and just ill-informed about what reality is going to look like for them. And so you now have a lot of people who are looking for Black doula training organizations like ours in order to make sure that they have the skills that they need. And this is why one training body or one training system is not going to work, because one system or the white standard is not effective for all populations. And unfortunately, you have organizations who are older than ours, of course. They're like the first ones who professionalize doulas, and they're more popular. And of course, they have more money, so they can do more advertising and things like that. So, society looks at these organizations as if they are the standard, but the Black community does not. We look for people who look like us to help us. I know I kind of went everywhere, but I hope that helped.
So
I'm gonna jump in and just
hi, sorry.
Hey, Natasha, you want to finish your thought?
Yeah, so I'm wondering where the gap is then. Is it among people of color, is it the need, right? Do we need to explain why this is beneficial so there will be need? Is it training for representative, so there's appropriate training for that group of people, or is it actual representation? Right, so there's those different segments. So where is the gap?
People just don't know.
Okay.
They really just don't know what doulas are. They're just learning about doulas because some celebrities have had doulas, and it's just kind of gone, oh, okay, a doula. Erykah Badu is now a doula. You know, she's been doing birth work for a while, so now people are like, oh, a doula. And so they think it's something, but they don't really realize what it is. And not everybody knows, you know, where to find doulas and things like that. But I can tell you, like, if I'm in a grocery store and I hear people, you know, talking about pregnancy, just 6 years ago, if I would have said to them, oh, I'm a doula, you know, are you interested in, you know, getting support? They would be like, what the heck is a doula? Now, if I hear people talking about pregnancy and I say, oh, I'm a doula in 2021, they're like, oh, really? So I can see that, you know, people are learning about what we do, but they're still unsure about exactly what we do. They're still getting confused with midwives. They don't know like what our role is specifically, how to get us, because most people can't afford the services. And so if they're not connected with one of the organizations that we're already working with, like Optimist or Healthy Start or whatever, they don't have access to doulas. And so we're trying to find ways where we can make this actually happen so that all families across the state of Connecticut can get a doula if they want a doula. But it's going to take a lot of work because, as I said earlier, we still don't even have enough doulas in the state. You have two large doula organizations or collaboratives here in Connecticut. One is Birth Tribe. Most of their doulas are white women. And they don't train their doulas. Their doulas get training from different organizations, but they all come together as a collaborative. And then there's Earth's Natural Touch, where we train all of our doulas and they can choose to stay within our organization or go off and start their own business if they want to, however they want to do it. So if you just look at the number of doulas between Birth Tribe and Earth's Natural Touch, outside of all of the other doulas that might be out there sprinkled around, you're still not going to get, you know, 120 doulas in the state.
So the current demand for doulas, though, is there enough to meet the current demand?
It kind of depends.
Right.
It kind of depends on who's demanding and what kind of doula they want. Are there enough white doulas to support? Yes. Are there enough Black doulas to support the women who actually need the support? No. Okay. Are there enough Black doulas to support the Black women who are asking for doulas? Yes, because
they're doing their research.
They're doing their research, right? But they're not the only ones who could benefit from doula support. So we have to figure out ways to actually connect with the people who could benefit doula support and start to talk to them about, you know, what that would look like. And we're trying to do what we can with the organizations that we are working with to make that happen.
Thank you.
So I just want to say, I've been trying to interject, but as like a very Black person, clearly in this, and I talked about it with our mini group, but right, it's also just like the lack of common knowledge in some sense. Like you can't anticipate somebody to do a job when they haven't been trained adequately enough to do that. So like, yes, it doesn't matter who your doula is, white, Black, Asian, Hispanic, Latino, but if they do not understand the capacity of what you're dealing with and they don't have compassion for the work that they're doing with you, then it's not going to provide you any service. And that's what the whole point of that is. And I think that that's what it really comes down to, is like a lot of our health systems don't want to be compassionate about it because they haven't had to for so many years. And I think that this is a way for us to say like, okay, we're anticipating and we're acknowledging the fact that this is happening. And this is one way that we're suppressing the lack of care in so many different organizations and so many different facilities of health for Black and brown people.
I tell my students on their first day of class, I usually ask like, what are some concerns? And sometimes they're like, I don't know if I'm going to be able to help, you know, if I'm going to make a difference, and I don't know if I'm going to feel adequate enough. If they walk out that first day of class and they go to support families, they'll be able to make a difference. It's not about necessarily the book knowledge. It's about the compassion and the love and the desire and the heart. I tell them this is heart work. This is not like head work. This is heart work. So if you want to do it, then you can do it. All of the other stuff is going to come later. And that's why we spread it out over 14 months. But I want people who are into this because they want to make a difference, not because they want to be a doula because it's popular in the moment. And so I agree, Stephanie. The studies, early studies on doulas show that even if you have a woman who is a trained doula and she's just sitting in the room with you while you're giving birth and she doesn't touch you, she doesn't say anything, you have better birth outcomes than somebody who doesn't have a woman sitting in the room with them. So she doesn't even necessarily have to do anything. Just knowing that somebody is there for you is going to help you have better birth outcomes. Now imagine somebody who is actually helping you and assisting you with navigating and reducing your stress, and even physically preparing for the birth and educating you on what's going to happen, what to expect, all of your birth options, checking up on you postpartum, making sure that you have food, helping you with latching the baby, making sure that your perinatal mood is in alignment with where it should be after you give birth. Then you have, it's just calculated, multiplied so many times all of these benefits. So it's just a matter of getting the word out there so that people know what we do and what because people also, you have to understand too, if Medicaid comes through, or just the fact that we're working through organizations, there is a huge distrust with the medical system, period. So if somebody is saying to you, oh, you can get free doula services, they're going to come to your home and they're going to do this. They're like, wait, hold on a second. They're going to come in my house. Like, are they going to report me if they see something? Are they going to judge me if I don't have enough food? If my house isn't, do I have to clean up before they get here? All of these things. So it's really on us to make sure that we're building relationships with the community so that they understand who we are and what we do. And that's what we've been working on, because we want people to be able to trust us. Right now we're in COVID, so we haven't been going to people's houses, but we've been doing a lot of virtual support, and that has been working as well.
Sayana, thank you so much for answering those questions. We are at 9:55. I just want to acknowledge that there were a couple of things in the chat. I know there was a question really briefly, if we could give a sense, Sayana, about in this region, how many BIPOC doulas are in this area?
So in the New London area, I don't have any. No. I don't have any Black doulas in that area. That doesn't mean that doulas don't travel. I know, Charmaine, there are some white doulas that are, all across the state. But like I said, most of our doulas are in Fairfield County, New Haven County, and even like Hartford area. And we have doulas that have spread out into other states as well, and even Germany. So, but we're trying. Oh, actually, no, let me not say that. There is a Black doula who contacted me maybe about a month ago. She is in New London. I can try to find her name. She registered for an event that we had, and then I never saw her again. So, but yeah, she is in New London. I do know one.
I'm so glad that we have a doula in the area. It would be really wonderful, I think, if there are doulas in this area, that we could share it among our network. Clearly, there's an interest and a way for us to kind of grow our knowledge around.
One of the things you have to keep in mind is that doulas are not able, well, some doulas are not doing in-person support. They're not even allowed in the hospitals. Only one person is going in. So we've literally been doing all of our support, for the most part, unless we have private clients or having home births and things like that, is virtual support. So from, throughout the pregnancy, the actual labor and birth, if the parent chooses to have somebody on virtually, and then even postpartum, everything has been virtual, which has actually been kind of working out because your doula can be anywhere. You don't necessarily have to have a doula in New London. You can have a doula in Stanford and still benefit from having doula services.
Thank you so much. I want to quickly just pass it to Stephanie to do our closing. One thing that I just want you to be aware of as HIC members is that we would love to have some information around your experiences in these meetings and how they impact your work. That's why we have these requests for information in the chat. Go ahead, Stephanie.
So thank you. I want to give a quick shout out and special thanks again to Ella and Daisy and to Sayana for sharing your work, for your presentations today. They have lifted my spirits in so many ways. So thank you. Anyone who is interested in, as Isabel just said, sharing your thoughts about the meeting, please feel free to put them in the chat or send a response email to the digest so that we know what you are appreciating or maybe not about the meetings, so that we can make them more effective and useful for everyone. And I'm just going to end by sharing again that we have the racial equity series next Wednesday at 7 p.m. It's about housing. And please mark your calendars for the next HIC meeting, which will be May 19th, 8:30 to 10 via Zoom. Thank you. And have a great day, week, all of the things.
Thanks, everybody. Again, please take a moment to just answer those questions in the chat. It really helps us tell our funder that it's worth funding us to do this work. And we really appreciate knowing how it's going with all of you. Thanks again and have a really great day.